Murthy. He's my mentor, my role model, and he has done an amazing work in the educational field of AAPI. And he's also the convention chair for the CME. And he's one person, you just give him, say, one word and he's done. That's already done. So he's always on top of things, very meticulous, very articulate, very coordinated. I'm happy to introduce Dr. Vemuri Murthy, the AAPI CMS Sessions 2020 CME Program Course Director and Chair of the Committee. Dr. Murthy is a well-known international resuscitation education and training expert and has been associated with American Heart Association in 3 different capacities over 3 decades. He's a visiting professor to several Indian medical colleges and universities, and is currently an adjunct faculty in the Department of Emergency Medicine at the University of Illinois at Chicago. He's also a chair of a Global Resuscitation Committee of AAPI. And Dr. Murthy, I had the opportunity to meet with him almost 10 years ago. We chaired the same educational seminar. We were the CME speakers, and I thought I should become like him one day, and hopefully I'll become a great speaker like him one day. Thank you, Dr. Murthy. Please take it over from here.
Thank you, Dr. Suresh, for your kind words. Good morning. Welcome to the AAPI Chicago Medical Society Collaborative CME sessions during AAPI 2020 Virtual Summit. The 3-day CME programs with AMA Category 1 awards for 8.5 hours, provided by the Chicago Medical Society, is structured to include diverse topics such as medical ethics, medico-legal, and workplace harassment courses, besides selected clinical topics of interest to all participants. An appeal to our colleague, US physicians, please submit your fully completed pre and post surveys to claim your CME certificates for the time you have attended the programs. Due to time constraints, the speakers can answer only a few questions selected from the wide pool of participants from the live charts. We request you to utilize the charts for questions only to prevent distractions during presentations. Our CMA committee, also represented by my co-chairs, Dr. Naveen C. Nanda, Dr. Rohit Kumar Vasa, Dr. Deepak Mittal, Dr. Vinod K. Bansal, and our advisor, Dr. Ranga Reddy. We thank AAPI President, Dr. Suresh Reddy, members of the AAPI Executive Committee and Board of Trustees, besides the leadership of the Chicago Medical Society for their help and support. We sincerely thank all the distinguished speakers contributing to the CME sessions. We thank all of you, the registered attendees, as member and non-member AAPI physicians, and our guests from India for your participation. Hope you will enjoy the 3-day CME sessions. We look forward to your support for the future virtual Indo-US CME programs of AAPI and Chicago Medical Society. It is my pleasure now to introduce the moderator of today's session, Dr. Naveen C. Nanda. Dr. Nanda is the Distinguished Professor of Medicine and Cardiovascular Disease at the University of Alabama at Birmingham. He is also a past president of AAPI. Dr. Nanda, thank you.
Thank you very much, Dr. Murthy, for the kind words, and it's nice to have this session with you as the chair of the AAPI CME program. I think we'll begin our session right away, and it's going to be medical ethics course here. And the first speaker is going to be Michael Huber, who is a clinical assistant professor of medicine, palliative medicine, University of Illinois at Chicago, and is also co-chair clinical ethics committee, University of Illinois at Chicago. Dr. Huber, please.
Thank you very much. And Dr. Gina Piscitello will actually be beginning. Thank you.
All right, so I will be starting. Do you want me to share my screen with the PowerPoint, or do you have it on? May I ask?
You can share if you want, or I can put it on.
Could you put it on, just so that we all have it?
You can see that now.
Perfect. Okay. Is there a way you could give me host access so I could move the PowerPoint as well?
Yeah, I think you need to request access for that so that I can do that.
Maybe I'll just try to share it myself. I'm sorry. I think that'll be.
Okay, I gave you access.
Okay. Here. All right, so sorry for that delay. Very nice to meet you all. So my name is Gina Piscatello. I'm one of the palliative care physicians at Rush Hospital. And I also do ethics consults at Rush as well. So I'll be starting the talk today, but there's 3 of us that will be doing the talk. So Mike Huber, who you just heard from, and then also Dr. Will Parker, who's a pulmonary critical care physician at University of Chicago and is assistant director of the McLean Ethics program there. All right, so starting off, none of us have any financial relationships to disclose. The objectives for today are to introduce clinical medical ethics to you all, review common ethical issues, describe frameworks for approaching ethical challenges, and discuss research allocation and unique challenges. And I just want to say with this as well, so if you do have any questions throughout, if you could just do the chat on the side, and we can try to get to your questions when we can. So we're first going to talk about the differences between bioethics and clinical medical ethics. So I think oftentimes, like in medical school, we're taught often bioethics, kind of the more theoretical, philosophical evaluation of ethical concepts. And it's very broad. It doesn't just include like clinical medicine. It includes basic science. It's much more large framework than clinical medical ethics. And I'm sure you've all heard about the 4 ethical principles of biomedical ethics, and that includes beneficence, so that means doing good for a patient, trying to help a patient. Non-maleficence, which means do no harm to the patient. Autonomy, which means respecting the patient's wishes and doing what the patient requests that we do for them. And then justice, which deals with equal allocation of medical resources. So that varies between, so bioethics, that's what bioethics is. Clinical medical ethics focus more on an actual clinical case. And there's 4 topics, or the 4-box method, that we use to kind of go through an actual clinical case. So this is more, instead of being more theoretical, it's like we're focusing on an actual patient and going through the actual issues facing that specific patient. So the 4-box method goes into evaluating the medical indications. So what is actually occurring with the patient? What kind of illness do they have? What are all the medical factors impacting that case? Patient and family preferences. So this is just like autonomy on the other side, focusing on what the patient's wishes are. Quality of life. So evaluating quality of life factors for the patient in the ethical case. And then contextual features, which is kind of a broad outline to look at, what type of legal issues are there? Are there religious issues impacting this? Are there monetary issues impacting the medical case as well? So this is just with the 4-box method. These are the 4 boxes. And for these cases that we're going to discuss, we're going to try to go through each of these components as well to see which components are impacting the case. So select topics in clinical medical ethics. So from the AMA Code of Medical Ethics, we'll talk about communication and decision-making, care at the end of life, privacy and confidentiality, medical research and innovation, and allocation of scarce resources. All right, and then the ground rules we kind of talked about, anything that you have any questions, just put them on the chat. and we'll try to get to them. So these example cases that we're going to discuss today, they are simplified. Normally there's a lot more components to cases that we actually deal with in real life, but just for the sake of the trying to get to each component of the discussion, they are a little bit simplified. And local laws do differ, so we will try to focus on that as well. I know, like, I'm from Illinois, so we have certain laws about like surrogacy for patients that differ from other states, and we'll get into that. And then also institutional policies may differ. So some things you were given kind of strict guidelines on legally what to do by states, but then things that aren't firmly hashed out by the state laws, institutions will make recommendations about. So there's kind of like what the ethical choices are, and those ethical choices, what might be the most ethical might not, you know, always match with what is legal in each state. So those are also important components to look at. And then seeking local guidance. So like if there is, you know, an issue or an ethical concern, reaching out to your hospital, you know, state lawmakers to try to figure out if changes need to be made. So starting off with topics in clinical medical ethics. So we're going to talk about consent, communication, and decision-making for patients. So the first case we're going to discuss is Miss C. She's a 60-year-old woman with type 2 diabetes. She's seen in the ambulatory clinic with fever, shortness of breath, and diarrhea. She's found to have tachycardia, hypoxia, and lab examinations shows acute kidney injury. The physician recommends admission to the hospital. Miss C is initially reluctant to go to the hospital. So with this case, can Miss C decide against the physician recommendation? So that's what we're going to talk about next. How do we evaluate decision-making capacity? So in this case, we kind of, you know, going through that 4-box method, you know, the medical indications of the case. So we're, you know, we know that she has type 2 diabetes. She's short of breath. She has diarrhea. Are there any medical concerns that might be impacting her decision-making capacity here? Well, she's hypoxic. She's short of breath. Like, could that be impacting her decision-making capacity? Absolutely. So that's important for us to know. She's initially reluctant to go to the hospital. So that's kind of when we look at what are the patient's wishes, those are her wishes. Now, are those her true wishes, or is she altered in some way because of her the medical factors? That's important to evaluate. Looking at quality of life, so evaluating that for this patient as well. Why is she reluctant to go to the hospital? Is her quality of life, does she think is going to be improved if she stays at home? Does she is going to the hospital something that she doesn't value for her quality of life? She doesn't want to go through those type of procedures. That's important for us to know. And then these contextual features. So we have nothing in this, you know, STEM to know about, like, is she worried about being able to afford the hospitalization or like an emergency department visit? Like, is that impacting her decisions as well? And that's so important for us to evaluate all of these factors when we have an ethical case like this. So if a patient has decision-making capacity, they can accept or refuse any medical intervention. But we need to first assess, do they have decision-making capacity? So how we determine it, there are guidelines for how we should be doing this. And I think just personally, I see a lot of variability in how this is done, which is kind of concerning because frankly, like a patient's autonomy, we should always respect a patient's autonomy if we can. If they lack decision-making capacity and we take away the right for them to make decisions for themselves, we better be spot on us, you know, on being totally sure that they cannot make decisions for themselves. So I think sometimes, like, I don't know if, you know, it seems to me that sometimes people just don't do the full evaluation of a patient. They just say, well, they lack capacity. And like that, you know, it can be very harmful to the patient because then we're not allowing them to make decisions for themselves when they might have capacity. So any physician can determine a patient's decision-making capacity. I know sometimes people think like, well, we need to get psychiatry involved or we need to get ethics involved to determine decision-making capacity. No, any physician can do it as long as they're comfortable with it. If you wanted like someone else to you know, agree with you, that's a reason to potentially get a consult from psychiatry or ethics on it, but any physician can do it. And then an important point to note, so physicians don't determine competence, judges do. So everything that we do, like in our notes when we write about patients' decision-making ability, we should be writing if they don't have capacity that we determine that they do not have decision-making capacity. Competence is a totally separate thing. It's determined by judges, and that's kind of taking away their ability to make decisions kind of full force. When we're doing capacity evaluations, we're making this at a specific time point that we evaluate the patient. because capacity can wax and wane. If people have delirium, they very well could have capacity at 1 hour, and then an hour later they lack it. And then an hour later again that they have it. So it's very important that we document if we say they don't have capacity, that at this time period, we assess that they did not have decision-making capacity. Also, it's question specific. So we really shouldn't be ever saying, oh, this patient lacks decision-making capacity for every single question. You know, it's question specific. So it's possible that a patient has decision-making capacity to make a decision about who they want as their power of attorney. They could be able to fully explain to you why they want this person as their power of attorney, and they have decision-making capacity to determine that. Now, maybe that same patient, that same time point, they couldn't tell you why they don't want a medical procedure done. Like they don't want a big surgery. They couldn't fully explain to you the risks and benefits of that procedure. So it's question specific and time specific. Now, the patient's totally out of it, like totally, like you can't even wake the patient up, then they don't have decision-making capacity because you just can't wake them up for any question. But if they can talk to you, we really need to make sure that we're asking them a specific question and we document that this question they lack decision-making on at this time point. So there are 4 components that we should assess for when we're evaluating decision-making capacity. The first is understanding. The second is expressing a choice. The third is appreciation. And then the fourth is reasoning. So these are from a paper in 1988 in the New England Journal of Medicine from Applebaum and Griswold. And these were the 4 components that were required to determine decision-making capacity. So we'll go through a case real quick to try to help understand how we use these 4 factors to determine it. So let's say for this patient, we would need to assess from her. So she doesn't want to go to the hospital, but she is tachycardic, short of breath. We're concerned that something's going on with her. So we need to have her be able to explain to us, what is the medical question? Does she have an understanding of this? So we would need her to say, I don't want to go to the hospital. So she has understanding of the question. We need her to express a choice. So she needs to be able to say, like, I am choosing not to go to the hospital. The third, she needs to kind of appreciate the risks and benefits of both. So she needs to be able to tell us, I understand that me staying at home instead of going to the hospital, that puts me at risk of dying, but I prefer that choice because, or the benefits of that choice is that I'm not going to be put through all these medical procedures in the hospital. Then, like, she also needs to explain to us, you know, if I go to the hospital, I might actually be treated and be able to improve. That's the benefit of going to the hospital, but it puts me at risk of getting like a hospital-acquired infection or putting me through distress by a blood test, that kind of a thing. So she needs to be able to appreciate the risks and benefits. And then the fourth is that she has to have reason. So she needs to explain to you why her choice is better than the other choices. So she can say, you know, the decision is, or the question is, do I go to the hospital or not? My choice is to stay home. She tells you all the risks and benefits of both choices. And then she says, I want to stay home because I want my quality of life to be focused on most importantly. I do not want to go to the hospital. I'm worried that people, you know, I'm going to be put through procedures there that will potentially harm me and worsen my quality of life. So I want to stay home for those reasons. She has decision-making capacity, that's it. And then we could document, you know, at this time, on this date, we assessed her decision-making capacity and she had it. Now, if she doesn't meet one of these 4 things, she doesn't have capacity. And at that point, then we need to go to someone else to help make decisions for her. Another important thing to note, sometimes people think, well, if someone's not alert and oriented ×3, then obviously they don't have decision-making capacity. And that's not necessarily true. Someone could be like, have, you know, baseline dementia. They don't know what time of the day it is. But if they have, for a specific medical question, understanding, they can express a choice for it, they can appreciate and have reasoning for their choice, they have decision-making capacity. So just because you have dementia, or if you have like a mental illness like schizophrenia, that does not automatically take you away from having decision-making capacity. You could be altered in some other ways, but as long as you have, you meet these 4 criteria for the specific medical question that we're asking you, you have capacity. So it's also very important because I think sometimes we, you know, we don't always fully assess. And then for some patients, we, you know, because of other illnesses, mental illnesses, we just assume that they don't have capacity. And that's not right. We should never be taking away their autonomy from them unless we do a full evaluation. So informed consent. So for any medical procedure, we're going to want to go through with patients, you know, from our side, the physician side, what the procedure entails, what are the risks and benefits of them. of those procedures. Informed consent. So, you think about in the hospital setting or clinic setting, like when you're doing a surgery or a procedure, that you have a patient sign a document, and that's informed consent. Well, informed consent is not the document itself. The informed consent is the discussion that you have with the patient. It is the process that is informed consent. In the end, they're signing a legal form, saying that, you discuss all these things with them. But it's very important that you're able to tell the patient exactly what the risks and benefits of procedures are, so they can make an informed decision for themselves. Some people will say that for certain procedures, a patient can never have true informed consent because there's no way that you can truly explain to them every single component of the procedure or the surgery and explain to them the risks in a way that they fully understand. I mean, you can tell them like, you have a risk of, respiratory failure following a procedure, and we might never get you off, we might never be able to extubate you again. You might remain intubated for the rest of your life. Well, can you really explain to that patient, if they've never been intubated before, what intubation is, what the experience would be like to them? There's certain points, like we're going to do our absolute best to get across to patients and try to get them the best we can to informed consent. But I think there's always going to be probably some limitations for patients because there's just no way we can explain things well enough where, unless they've experienced it themselves, they wouldn't understand. So even like if you were trying to get informed consent from another physician, they might have a little bit better knowledge about what you're explaining to them. But they might not have a full awareness without having experienced it, all the risks and benefits of a procedure, and truly understand what they're getting themselves into. So again, informed consent, it's very important. We should be assessing a patient's decision-making capacity again with informed consent. Oftentimes when we assess decision-making capacity, we only do it when we're concerned that there's something up, like, someone's making a decision that we disagree with. So then we assess their decision-making capacity. Really, it'd be great if we could assess decision-making capacity for like these big medical questions all the time, just to make sure that patients are meeting these components of medical decision-making capacity, especially when we do informed consent for big medical procedures. But I think, oftentimes, and I bet you've seen this in practice as well, we only kind of assess their decision-making capacity when they're making a choice that we personally disagree with. And because we disagree with it, then it's like, oh, something triggers in our mind, hey, they must not have decision-making capacity because this doesn't make sense. And then we evaluate for it. And so how often are we missing patients that lack decision-making capacity because, like, let's say they agree to it and it goes along with our own opinions for what kind of medical care they should pursue. So that's another thing to keep in mind as well. So informed consent, so we want to talk about medical indications, burdens of treatments, risks of treatments, benefits of treatments, and then also alternative choices as well. And I think oftentimes, sometimes we need to check ourselves as physicians, like our own biases. Sometimes, do we provide all the options to patients? When you see a patient come in that's critically ill, and you're talking to like the patient and the family, it might be your inclination, like, of course, like we need to treat the patient and make sure, do our absolute best at, save their life if we can. But, for that patient, how often do we miss patients that they would have never wanted those life-saving interventions to begin with? Like quality of life was more important to them than doing those life-saving interventions. And it's just that no one asked them what their real opinions were about it. And I think like we know this, like how many patients are come into the emergency department, are intubated, and then later on we find out that they have a form completed that they wanted to be DNR. This happens not infrequently. So I think it's very important, like the best that we can, to be aware of our own biases as well, like with what we think patients should receive, and just make sure that we're providing other alternative options as well that are ethical choices, just to make sure that we're honoring patients' wishes about this. So for case one, the physician does assess Miss C, and she does determine that the patient has decision-making capacity. So what is the preferred approach to decision-making? So back in the day, so the dominant practice from like antiquity to the mid 20th century was paternalism. So physicians would just kind of tell patients, well, this is what is the best choice for you, in my opinion, and this is what we're gonna do. And it was expected that patients follow the physician's recommendation on it. So that went up through like the 1960s. Sometimes you'll hear about that. It's like the golden age where physicians were respected. What they thought was best for patients, that's what the patients followed. There wasn't really disagreement with things. So that's, one way of doing things. And then now, recently, and I think things have dramatically changed, especially with medical education as well. Like when I went through medical school, it was very much what the patient wants, we should give them. Like we are almost like just technicians. Like the patient comes first. we need to protect patient autonomy. What they tell us we should just do. So that's definitely gotten more advocacy in the recent past. And this view would be that the patient comes first, we just provide information, and then we let the patient pick off a platter, and they can make an independent decision from that. We'll talk about the potential harms for that in a bit. Now, shared decision-making, this is the ideal system where we make a decision with the patient. So the patient shares their experiences, goals, and values. The physician gives medical information to the patient and can give the patient a recommendation as well. And then it's a mutual decision between both the patient and the physician. Why this is generally preferred. So it's great to be able to give patients the right to make decisions for themselves. Like that's absolutely, we want them to do that. But can a patient truly have full informed consent of the medical procedure or whatever you're talking about with them? So the patient's going for a massive surgery, you know, you could tell them all the technical aspects of the surgery, what the risks and benefits of like survival are. Does that patient truly understand what they're going to be going through, the whole process of the surgery? And I think for many times, like they aren't able to fully grasp that. Now, you as a physician, you do have better understanding of exactly what the surgery entails, what the likelihood the patient's going to benefit is, what the patient's going to have to go through. Like you've seen patients go through this in the past. So you do have knowledge that you can impart to that patient that could be helpful to them. So ideally, you know, you want to hear from a patient for any kind of medical decision. First, get from them, what are your goals and values? Like what is most important to you? And then you can kind of use what they've said to you and combine that with your medical knowledge to say like, hey, this is what you told me. From my medical knowledge, this is what it sounds like you want. This is what I recommend that you do. Some people are very against physicians giving recommendations to patients because they think like potentially that could be harmful, that, you know, the patient then feels obligated to take your opinion. One way to get around that is you could just ask the patient, are you okay if I give you a recommendation? I think, you know, and this is kind of an ethical choice that you need to make, that I think we all need to make. You know, are you just a technician where you just provide all the options and the patient chooses? Or is there something more to you where you were able to, you know, have a different understanding of these medical procedures and things that you're offering to patients? And like, it is, you know, within reason for you to help patients, you know, and give them recommendations to help support them and get them to where they actually want to be according to their goals and values. So I think, of course, there could be harm in us giving recommendations to patients. Like some people might be like, oh, you know, you're just like, you have no fundamental understanding of me as a patient. Who are you to give me recommendations? I want to make this choice. So we discuss this with like code status. Oftentimes we're like, you know, you might see a physician give a recommendation to a patient. Well, I recommend you be DNR. And then the family's like, well, you know, you're trying to kill my family member. And then you run into losing trust with the family. It's a big deal. But I think if you just assess the patient's values and wishes first, you get around a lot of that, because you can say, hey, this is what it sounds like the patient wanted. You know, the patient, they hated going to the doctor. They avoided it at all costs. You know, us doing CPR on them, that sounds like, you know, that we might be doing things that aren't in line with their wishes, because if we do CPR and they are resuscitated, they're going to be on life support, and they try to avoid being, you know, at the doctor their whole life. So it is a way that can kind of get around some conflict as well. When you're trying to assess the patient's wishes, and like, it looks like you're actually, you know, trying to respect the patient and trying to follow those values that they have. So for case one, the physician discusses Ms. C's reasoning, goals, and values. The medical information aligns with goals, and Ms. C does consent to admission after discussion. All right, so now we're going to go on to case two. So Mr. M is a 42-year-old man with no medical history who presents to the emergency department with fever and hypoxia. He's stuporous but awakens briefly and refuses an IV and oxygen by nasal cannula, stating, "I'm fine, leave me alone." He is confused and unable to answer questions. The emergency department physician determines Mr. M does not have decision-making capacity. So who decides if a patient cannot? So ideally, this emergency department physician, he went through those 4 components of decision-making capacity and made sure that this patient did not have capacity. Even if a patient's stuporous, potentially they still could have capacity. So you really need to go through those 4 components. Now you're always going to run into this issue as well. Well, you know, the patient might lack decision-making capacity, but can you force something on them? Like, should we, if a patient lacks decision-making capacity, should we forcibly restrain them and give them procedures? In some cases, yes, we do that. In other cases, it's fundamentally impossible to do it. So that's another issue as well, but we're gonna get into next. Who decides? So this patient, he doesn't have decision-making capacity. Who should be the right person to decide for him about medical decisions? So we are always gonna go, number one, if the patient has previously expressed wishes about their medical care, we are always gonna go to the patient's wishes before anyone else discussing with them. So if a patient comes in and they have a form called a POLS form, a MOLS form, which is like a DNR. Like if a patient comes in, they have a signed DNR form. And I can speak specifically for Illinois, and I think we'll get into this later as well. That form states that no one can override that DNR. Not, even if we're gonna get into power of attorney and healthcare surrogates in a second, but no one can overturn that DNR form. That's what it says in the form. Unless the patient changed their mind and they told someone else that they changed their mind, that form stays. So anything the patient's written wishes, we always should be going for that first and respecting it. So if a patient has a living will, and like that living will says, if I'm terminally ill, do not, let me focus on my comfort, do not resuscitate me. And then someone else is saying in the family, oh no, don't do that, I want the patient to live. We are going with that patient's word first. We always should be, as much as we can, going with the patient's word. Now, we'll talk about in a second, because sometimes legally family can bring up issues with that. And then we might have some other avenues we need to take, but morally, patient comes first, patient's written wishes we're always gonna go with, if we can. So the patient has no written wishes. We want substituted judgment used by a patient's power of attorney or healthcare surrogate to help determine a decision for the patient. So states vary on what they call a decision maker for a patient. So it could be alternate decision maker, it could be surrogate, it could be healthcare agent. These terms vary by state. And I'm gonna show you a graph in a bit that kind of shows the variation, because there's a lot of variation in the US. So these terms vary. It is important for you to know whatever state you're in, to know what terms are used in your state so you're accurately reporting it. Alternate decision maker is kind of the broad term that's used to kind of define everything. So if you're not sure like what state your state protocols is for how do you define a decision maker for a patient, using the phrase alternate decision maker, that's always right. That encompasses everyone. So like in Illinois, we have, so power of attorneys are patient designated people to speak on their behalf. So the patient had to have decision-making capacity at the time to be able to designate another person to speak on their behalf. So that's that component. And then a healthcare surrogate in Illinois would be if the patient doesn't have decision-making capacity, didn't make a power of attorney, then by law, a healthcare surrogate is determined for them. So we always would go with the power of attorney first, so that's patient designated, but then if they don't have one, we're gonna assign someone to them, and that who we assign is based on state law. So every state values powers of attorneys, that's always gonna be number one, but then the healthcare surrogate, that's how that is determined differs by state law. Substituted judgment, what we want this decision maker to do is to tell us what the patient would have told us if they could speak. So we need to be talking, when we talk to these alternate decision makers, based on what you know about the patient, if that patient could talk to us right now, what would they tell us? We always want them to say what the patient wanted, not what they want. Because sometimes you say, well, what do you want for the patient? And then they're like, well, I want the patient to live. Then you're in like a real bind, but if you can phrase it to them, please tell me what do you think the patient would want? It takes away some of the burden from the family as well. Because it's like the family, sometimes these decisions, life and death, are very difficult for them to make. And if you can help them say like, no, this isn't your decision. This is what would the patient have wanted. Tell us what the patient would have wanted. That can alleviate a lot of the burden from the family as well. So substituted judgment, if we don't have a written documentation about what the patient's wishes were. And then if there is no documentation and there's no healthcare surrogate that we can find, then we would use the best interest method. The best interest method means that in your physician opinion, this is what's in the best interest of the patient based on what you think like the normal patient would want in that setting. So this is the slide. This is like a fantastic slide. So this is looking at how do you determine an alternate decision maker based on state? And you can see there's a ton of variability in this. So this is a study by DiMartino et al. In the New England Journal 2017. And you can see, so I'm speaking from Illinois here, you can see in our state, it's the darker blue, which means that if the patient doesn't have a power of attorney, someone is going to be assigned to them based on state law. So in Illinois, if a patient doesn't have a power of attorney, by law, we're going to go to their spouse, their legal spouse, of course, because that's an issue as well. If they say, oftentimes people will say like, it's my spouse, and they're not a legal spouse. If they're not a legal spouse, they're not on the list first step. So legal spouse, then in Illinois, it's adult children, all of the children equally. So it would be majority rules for that, but that differs also by state. So it would be spouse, adult children, parents, adult siblings, adult grandchildren, close friends, guardian of the state in Illinois. That order varies by state as well. So it's very important wherever you are that you look at what that order is. Now, some states have no order. So you can see like in Minnesota, the physician determines who the right surrogate should be to help make decisions for a patient. So if a patient doesn't have a power of attorney, the physician goes to the person, the moral surrogate. So what a moral surrogate is the person that knows the patient's wishes the best, so they can speak on the patient's behalf. So ideally, we all should be going for the moral surrogate. We want to know the patient's wishes. We want to respect their autonomy. So in Minnesota, the physician determines who knows that patient the best to make decisions on their behalf. So if it's the patient's ex-wife, but that ex-wife, you truly believe they know the patient's wishes the best, that's who you're going to go with in Minnesota. Whereas in Illinois, it doesn't matter. Like that ex-wife could be the person that knows the patient the best, but by law, we cannot go with her. We must go through the order. And so, for sake, like in Illinois, if, there's a spouse, we need to go to the spouse first step because they don't have a power of attorney. But what if that spouse is abusive? Well, then we got an issue on our hands, and that's a legal issue. And that would be something you would need to escalate through your hospital and then legal department as well, because we don't want someone that's abusive to be making decisions, but just by law, that would be the person that's first step. And then how should the alternate decision maker make decisions for patients? Ideally, they make them for what the patient wanted. So we talked about substituted judgment. So always, if the patient has expressed their prior wishes to you as a surrogate, that's what you should go with. Or just kind of by how they live their life. If they hated going to the doctor, this happens quite a bit where, we'll see a woman who's like in the ICU, intubated, sedated, and I'll talk with her son, and the son's like, she hated going to the doctor. She was biting and screaming and pushing us off of her as we got her to the hospital. Well, that kind of tells what her wishes were. Like if she fundamentally hated being at the doctor, here she is on life support. This is not her wishes. And, we as physicians can kind of help guide that, the family with that decision as well. And then pediatric decision-making. So that's a little bit different now because pediatrics, the adults, the parents or guardians are going to be consenting for the patient. So parents have the authority to make the decisions, but we still should try to evaluate minor patients to determine their understanding, and then try to seek assent from the patient. So, adults consent to procedures. Pediatric patients assent, which means like they can agree to it, but like, legally they're, just because they assent to something doesn't mean we're going to do it necessarily if the guardians have true authority over those decisions. Now, in some pediatric cases, a parent isn't needed, and that's also state dependent, but just for certain medical decisions. And then we should explore dissent with children also, if we're able to. So for this case too, Mr. M's wife is identified as a surrogate decision maker. She feels he's not himself and he would want treatment. And so she consents for treatment for him. And this is very important. Just because the patient declines it, if the patient's true wishes were to get treatment, thank goodness we have a good surrogate here to speak on his behalf for it. Mr. M does improve with oxygen and supportive care, and he's discharged home. So I think, kind of overall with this, just making sure that, we do our absolute best to try to find the right decision maker for the patient. And by law, we find the right decision maker for the patient, and always encouraging them to please, speak on the patient's wishes. I can't stress that part enough, just because like we run into so many issues with these decisions for patient care, because these families or friends making these decisions, what a horrendous burden on them. And we know like there's increased risk of like PTSD symptoms after people are making these life and death decisions for families. And sometimes it can really relieve the burden for you to say, please speak on the patient's behalf. What are the patient's wishes? It sounds like a minor thing, but it's so big. In addition, I wanted to mention real quick, this is my last slide, and then I'm going to hand it over to Dr. Mike Huber, that giving surrogates, healthcare agents, power of attorneys, the ability to decline decisions, no one is ever forced to make a decision on behalf of the patient. If a person's so uncomfortable they cannot make the decision, that is totally fine. They can decline it, and we should offer that as a choice to them. But if they do decline it, then we just need to go, by law for our specific state to the next person in line for that medical decision. So sometimes, like, for Illinois, if there's 6 children that are supposed to be the correct healthcare surrogate for the patient, and 2 of them decline, that's totally fine. Then those other 4 are going to make those decisions. Now, if there's other issues with that as well, and that's state dependent. So make sure you check your local state statutes on that. But I just wanted to mention that part as well, because I think oftentimes we don't give healthcare alternate decision makers a choice about this. So with that, I will pass this over to Mike Huber.
Thank you so much, Gina. And I will take over. Ms. Gadali, if you can stop the screen sharing, I'll screen share my PowerPoint. All right, we can do it off these slides. Thank you, Gina and Dr. Piscatello, and thank you so much, AAPI, for the opportunity to speak to all of you about ethics. I'm Dr. Michael Huber. I'm an ethicist and palliative care doctor at the University of Illinois at Chicago. And we'll begin talking about another issue that is within the AMA Code of Medical Ethics, which is ethics for caring of patients at the end of life, something that Dr. Piscatello and I do clinically. So moving into another case, Mrs. J is a woman with advanced dementia characterized by being non-ambulatory and nonverbal. She is admitted to the hospital with fevers and develops worsening hypoxia. She is noted to have sacral wounds on admission. The medical team speaks to her daughter, who is her documented healthcare power of attorney, about her care. So thinking through the clinical ethics approach, medically, she is showing signs of a terminal illness in the end stages, characterized by her functional state in relation to her dementia. And in terms of patient autonomy, by nature of being nonverbal, she globally does not have decision-making capacity. She's not able to meet the criteria that Dr. Piscatello laid out well. And we identify her daughter as a surrogate or her healthcare power of attorney. So her daughter manifests her autonomy and would be expected to use substituted decision-making. Thinking about contextual features and other components, we don't have a lot of that listed in the case, but are always parts of what we should bring to this decision. But the question is, how should decisions be, decisions about end-of-life care, which is really where we are with Mrs. J. She has signs of a poor prognosis, certainly expected life expectancy less than 6 months, and is now presenting with an acute illness to the hospital. And you may notice in some of these, or in all of these cases, that they may unfortunately be familiar to you as we are choosing cases that indicate patients that may be presenting in current states with COVID infections. And I think that right now is a time where we are seeing profound ethical challenges related to the COVID, but also just basic ethical issues that really we confront every day, but are seen certainly in many of these cases, such as this woman with advanced dementia who, if we were seeing her in the ED in the current setting, we would certainly be worried about COVID. So she's arrived with acute illness and a terminal diagnosis, but how should we hope that she would have planned for this situation? So advanced care planning is a process. I explain it to patients as a process in which you get to give voice to future decisions for a situation where you wouldn't be able to express your choices for those decisions. It really is a process. It should be ongoing and evolving. It should occur in all settings, outpatient and inpatient. Really, it is the ideal. You know, Dr. Piscatello explained well, you know, how a surrogate decision maker should make a decision for a patient when they can't make a decision for themselves. And so to be able to do that, substituted judgment, to know, you know, what the person you're making the decision for would likely want, you need to have been able to have some sense of what they would want. And that is the only way that that's going to happen is with a process. And the physicians and other practitioners should be central to this process long before a patient is in a state where they don't have decisional capacity. I think there's been universal recognition, you know, going back from the mid-century of the importance of this, but recognition of the importance, unfortunately, has not translated to widespread, high-quality advanced care planning. A relatively recent systematic review demonstrated that among 800,000 patients, patient records reviewed, less than 1/3 of adult patients in the United States had any sort of formal advanced care planning completed. And I'm sure that all of you who are in practice, you know, see this and know this all the time, that unfortunately, you know, we're meeting with patients who don't have decisional capacity, and this process has not occurred. And we as the care team and their surrogate decision makers are often left without, you know, perhaps the right information to make the choices. There are many types of advanced directives that Dr. Piscatello had already mentioned, and we'll talk about in more detail. These types of advanced directives are documents with varying legal power and authority. Whenever I'm discussing advanced care planning with patients and their families, I say that the documents are necessary but not sufficient, by which I mean, especially for legal reasons, completing actual physical documents is extremely important. But the documents themselves are always going to be limited, and the only way to really achieve true substituted judgment in advanced care planning is a process of communication. And it's one, like I said, that occurs over time. So, you know, filling out, and we see this a lot, you know, somebody will present to the hospital without decision capacity, and they'll have a document such as a living will that was filled out 20 years ago. And that, you know, no discussion has occurred since then. So really, it's got to be a process. It's got to be ongoing. It's got to happen, you know, with any change in the patient condition or medical care. But there are different types of documents. The first is the durable power of attorney for healthcare. These are state-level documents. They vary by state and state statutes. So again, you know your local legal. But in general, these are documents that give legal authority to make medical decisions for patients who cannot make decisions for themselves. The durable power of attorney for healthcare can be important, particularly in many states. It gives more legal authority to the decision maker than they would have if they were just assigned surrogate decision making. And thank you. I see questions in the chat. I think what we'll plan on doing is saving them for the end of the session and getting through as many as we can. For the durable power of attorney for healthcare, like I said, it gives more legal authority than someone who is assigned a decision maker just by state statute in the absence of the document. I see these terms used interchangeably quite a bit, particularly in the medical record, where healthcare power of attorney is used almost as a colloquialism to mean decision maker. when there isn't actually a document in place. It's just that someone was assigned or is the appropriate decision maker by statute. They're often referred to as the power of attorney. Those would be actually surrogate or substitute decision makers, but unless there's an actual power of attorney, they would not be considered that and wouldn't possibly have less legal authority. So it's important to make those distinctions. And when you're treating a patient and hearing, from colleagues or other teams that someone is the power of attorney, ensure that they have a legal document and or what authority they have. The other thing to know about the durable power of attorney for healthcare is that it's a document that someone must have decisional capacity at the time they're completing. Like Dr. Piscatello explained well, somebody may have trouble with medical decisions or complex processing of information, and we may determine that they don't have capacity to make a decision about a big surgery or something like that. That doesn't necessarily mean they globally don't have capacity, and they may have capacity to be able to fill out a durable power of attorney for healthcare. But if a patient truly does not have capacity, similar to the patient in our case where she's not able to speak, not able to demonstrate any sort of capacity, she would not be able to fill out a healthcare power of attorney. And if she didn't have one, then we would use state statutes to find the appropriate substitute decision maker. Oftentimes on consults or in various situations, we're asked or thought of to complete a healthcare power of attorney for patients who clearly don't have capacity to be able to do that. And then it's just a matter of explaining the situation and being clear that they would have a decision maker by substitute authority, not by a healthcare power of attorney. The Living Will is the oldest advanced care planning document. It grew out of actually estate planning legal documents and first came about in the 1970s. It corresponded to a time when there was a rapid increase in medical technology and life-sustaining technologies such as ventilators and artificial nutrition. And there began to be more interest in patients being able to plan for and express specific wishes. And so the Living Will became a legal document to this. This again has to be completed by somebody who has capacity at the time. And they also vary by state and vary by the level of detail or what the documents say. Oftentimes, like I said, I've encountered patients who have completed a living will in the distant past, often as part of, sort of financial estate planning or other planning. And then they feel, okay, my wishes are known, I have this all in a document. Unfortunately, while the living will does give and can give specific directions around things like the use of ventilators or the use of artificial nutrition or other things, the way the documents are worded, necessarily cannot account for every situation. And as we all know, we end up, especially at the end of life, in complex medical situations where patients often lose capacity before their death. And so when patients have a living will, I say again, that's very good to have completed and it's necessary, but it's not sufficient. I always explore with them and encourage them to discuss with their family, all the components that would need to go into true substitute decision making. I say it's much more important to have a conversation with your family about who you are, what's important to you, generally what states of being and life would be considered acceptable to you, and have those broader or more specific conversations with your family. And then some of those decisions could be reflected in the living will, and the physicians can help interpret that. But really, having a more general conversation about what's important to you is as or more important than actually filling out the living will. The MOLS, which stands for Medical Orders for Life-Sustaining Treatment, or POLST, which stands for Physician or Practitioner Orders for Life-Sustaining Treatment form. These are actual medical orders forms. They've grown out of a national paradigm wherein there was recognition of difficulty in maintaining the durability and the transmission of patient wishes, particularly around CPR. Because CPR happens by default, there was recognition of a need to have a way to document in a durable form the patient's wishes that they can have with them, if they are in a situation where they're moving across healthcare systems, or experiencing emergency medical services or situations like that. This is a national paradigm, but it's implemented at the state level. And again, like all of these things, the statute's different across states. The one I'm showing here is the Illinois form. What's important about this document, and again, it varies by state statute, but in general, those states that have adopted it, these are physician orders, similar to any other order you would give. And in that way, have the capacity to be acted upon by other practitioners, particularly, EMS services can accept this as a standing medical order not to perform CPR or to perform CPR. You can make the choices of either kind on these wishes. This document, I really, of all the documents that can be used for advanced care planning, the healthcare power of attorney, to make sure we have legal authority for the person you want to make a decision. And then this document, if you're in a state that has this paradigm, I think are the most important. Again, there are always contextual features and, changing clinical situations. So this document shouldn't be a standing, one-time thing to fill out, and it should be readdressed. But certainly, if you encounter a patient who is clear that they would not want CPR or intubation, or there's other measures on the document like artificial nutrition, if you're in a state that utilizes this paradigm, you really must have the patient fill out this document. Unfortunately, I see sometimes use of the orders in the hospital and the electronic medical record, or a documented conversation in the outpatient and a note in the electronic medical record that does not end up resulting, about a patient's wishes to be DNR, that does not end up resulting in this form. And if you're in a state where this is accepted, then it really is important to do this and to explain to patients, explain to patients how to use it and the importance of it. Sometimes it can be an intimidating document. The Illinois form you're looking at has a big black border and says DNR on it, which can be charged language or communication. But if the patient has clear wishes, I really do ask them to make sure that this document is available for patients who are near the end of life in a comfort focused setting in hospice care. I'll often ask that they display this in an area. EMS generally in the states that have this paradigm know to look in certain places, like taped to the fridge or taped to, above the bed, for patients where if they end up in a situation where they're called, they can then recognize that these are standing orders. So again, these are some of the documents. I impress and cannot impress enough upon patients that the documents are extremely important, but what is much more important is the process of discussion with all your physicians, discussion with those people who would be your surrogate decision or substitute decision makers about the importance of what you want, sort of a general, what they need to make substituted judgment, who you are, what's important to you, what types of life would be acceptable. So those are the advanced care planning documents. So despite Ms. J having completed a healthcare power of attorney and doing advanced care planning in that way, which is important, and we know her daughter is the specific decision maker because that document was completed in the past when Ms. J had capacity. Unfortunately, they fell into what we see from the research is the more than 2/3 of patients that had not, discussed much about advanced care planning and particularly code status. I know this is something that we all run into a lot. And it's unfortunate when we're meeting a patient in Ms. J's situation who has advanced and terminal illness and is now presenting with an acute illness. A brief discussion in the ER leads to a wish from her daughter, or her daughter believing through substituted judgment that her mother would want to do everything. I'm sure that this is not a situation that is unfamiliar to anyone who has practiced in acute or other care settings, and can be, it's very common to hear, the question of doing everything. And what does that mean, particularly when we're talking about CPR? So as I discussed with the MOLS and the PULSE form, discussions around code status, do not resuscitate orders, or do not attempt resuscitation orders are an extremely important part of advanced care planning, because those things would happen automatically, often even before we'd have a chance to talk to your substitute decision maker in an emergency setting, before we've had a chance to get to know, from your substitute decision maker, if you can't make decisions, what would be important to you, what types of care you would want or not want. Of all the decisions to make in advance, I impress upon patients that this is or may be the most important, because this is the attempts at CPR or the attempts at resuscitation would be something that would happen suddenly, and we wouldn't have a chance to talk to your decision maker. Unfortunately, however, similar to the lack of widespread advanced care planning, these conversations often do not happen, and more often than not. Even when they do happen, unfortunately, they don't happen in a way that helps arrive at true shared decision-making around CPR. CPR is a medical procedure like any other procedure, like a surgery, like a starting of a treatment regimen, and it should be addressed in shared decision-making in that way. It should be addressed as an informed consent process, similar to how Dr. Piscitello described. We should be talking about what is CPR actually, what are the medical components of it, what are the expected outcomes of it, what are the risks or the benefits of that procedure, how likely is it to achieve the goals, and what are the alternatives, which I don't think, unfortunately, is something that is often done in a robust fashion. I was walking down the hall yesterday. The new interns have started in my hospital, and I passed a patient room where an intern was doing an admission, doing a wonderful job as a new intern, getting all the medical history. But then I saw my patient was walking back past the room, and he was finishing up his encounter, and he said, if your heart stops, would you like us to try to restart it? That's one way to present CPR. And there's actually data, including studies where they've recorded both residents and hospitalists in different institutions. There's multiple single institution studies where they show that is generally the approach that many take. There was a study out of the University of California at San Francisco Hospital looking at hospitalists that showed that on admission, a hospitalist spent a median of less than 1 minute discussing code status with the patient, and that those discussions did not include almost any of the components that I discussed. So, low quality, unfortunately, discussions that result in uninformed consent is how I often put it. Where we're asking a patient, if your heart stops, do you want us to restart it? If you ask me that, I would say yes. If I didn't have the medical information or understood, why wouldn't I want that to be the case? Which is very different than a robust discussion that takes into account the patient's illness, their prognosis, their expected outcomes from CPR, and what their goals are, and whether the attempts at CPR would align with those goals. So really, I encourage everyone to try to treat CPR discussions as an informed consent process like any procedure, and really being candid about all those aspects. Thinking especially about the outcomes of CPR, I think this is where one of the major disconnects with patients, but also with providers really is. I know we have resuscitation experts, on this call, and I think I'm always surprised by the answers I get to this question. But again, this is in hospital cardiac arrest. What would be the likelihood of the return of spontaneous circulation? So just successful CPR, return of spontaneous circulation for in-hospital cardiac arrest. And it's really only up to half or less than half of hospitalized patients in the hospital setting who even have successful CPR. The intervention itself achieves its physiologic goal. And out of hospital cardiac arrest is less than this. And I think that's really important to discuss with patients. For those patients, beyond just the physiologic success of CPR, but actually the likely goal of what most patients would express, which is getting out of the hospital alive, what is the likelihood of that happening for patients who have a cardiac arrest in the hospital? So much less, only 10 to 20%. And if you, the data for patients with some diagnoses such as advanced cancer, advanced dementia is even less than that, at generally less than 10%. And so, I think that's really important to explain to patients, and there often is a disconnect or a misconception. There was interesting studies that watched hours and hours and hours and hours of television shows from medical dramas to look for instances of CPR and then find the outcomes. And the outcomes that patients who are watching these shows, it goes back to the 90s, like St. Elmo's Fire and ER and all those great shows that I like to watch on reruns. But the ROSC rates were up to 75%, and survival to discharge were 2/3 in those cases. So the vast majority of patients have no experience, with CPR, and they just know what they watch on TV. The other thing I would say about that, that wasn't recorded in these studies is, we know from watching TV that CPR often looks like a gentle, comfortable process that doesn't even have any sort of ventilation or even a bag mask, and it may look like very minor sort of gentle compressions. I shy away from trying to scare people out of CPR, which is another thing I think I often see trainees doing by trying to oversell the harm or the suffering that may come from the procedure itself. But I do think we need to give very frank discussion of what CPR actually looks like, what it entails, what mechanical ventilation and intubation look like or entail. And so, explaining the procedures, but also alleviating this misconception. And then, this continues through even, there's repeat studies in more modern eras. The dramas have not gotten much better, but they have gotten a little bit better where fewer people are surviving to hospital discharge. So a study that evaluated elderly patients and asked them what they believe their chance of survival would be, the vast majority of patients expected survival from CPR as being much higher than it actually would be. And so when we talk about CPR, we really need to make sure that we are giving clear expression of the expected outcomes, which is something that I really think is missing from these conversations. And in my own practice, when assessing goals and values and beginning to align those with the expected outcomes, I often am able to make a recommendation that patients then can have a much more informed and shared decision-making process. The other part of the outcomes that I think is really important to explain is even for those patients who achieve return of spontaneous circulation, and even for those patients who survive to discharge, there is often very significant morbidity. I think the other thing that comes out of these TV shows is, somebody goes through CPR and then, at the end of a 20, 30, 1 hour episode, they're fine and they leave the hospital. When in reality, almost certainly, and particularly for patients who have, advanced illness or comorbidities, even in the situation of successful return of spontaneous circulation, that's often followed by a prolonged intensive care unit stay and significant debility, being significantly weaker or with neurologic changes compared to how they were before. And even for those patients that are in those numbers that survive to discharge, many of those patients aren't able to discharge home even though they came from the home, but are discharged to skilled facilities with a significant change in their quality of life. So I think all of those things are really important and really need to be brought to these code status conversations and aren't at all encompassed in the question, if your heart stops, do you want us to restart it? And really ethically, we need to be bringing all of this so that patients can make a true informed consent decision around CPR. So back to the case of Mrs. J, a combination of the ER physicians and communication, thankfully with the patient's primary care provider who was able to call into the ER with Ms. J's daughter. She felt that, shared decision-making around the prognosis and those decisions that her mother actually would not want mechanical ventilation or CPR. Which raises the question, ethically, can life-sustaining treatment be withheld or withdrawn? Now, all of you who are in practice and practiced in intensive care or acute care or end-of-life settings, I'm sure have been involved in the withholding or withdrawing of things such as ventilators. So this seems like a settled ethics question, and it's true. The general ethical consensus is that patients who have decisional capacity may elect to withhold or withdraw any medical intervention, just like we said at the beginning with patient autonomy. That's even if the decision is expected to lead to death, and even if the individual is not terminally ill. The patient themselves, if they have decision-making capacity, generally ethically, it is felt that their autonomy extends to make those types of decisions. The other component to this is that withholding and withdrawing interventions is considered ethically equivalent. Emotionally, this often feels very different, both for practitioners and for families, patients, or surrogate decision makers. But from an ethical, philosophical standpoint, the idea of not intubating, not intubating Mrs. J, which is her wishes, would be the equivalent ethically of withdrawing a ventilator if Ms. J had been ventilated and then chose, or her surrogates decision makers chose at a later time to withdraw. I think that's something, it's sometimes hard for families to wrap their heads around and feels emotionally different, but ethically is equivalent. So patients themselves have really broad autonomy in these decisions. Surrogate decision makers, in general, ethically, may withhold or withdraw interventions within the general ethical guidance that we've talked about for surrogate decision makers, using substituted judgment and making those decisions. However, the law varies, and state law varies and can vary widely in what surrogate decision makers are allowed to do, particularly in terms of withholding or withdrawing life-sustaining interventions. And so this, again, is another one of those areas we identify that you really need to seek local guidance. So I said at the beginning that, it seems all of us through our training and practice, or certainly most of us, have been involved in the withdrawal of a life-sustaining intervention. It seems like this is a settled area, but it certainly was not around the time that these interventions were being developed. With the widespread use of ventilators beginning, into the 1970s, there was actual societal, legal, ethical, physician-level concern about the idea of, withholding or withdrawing life-sustaining interventions. There were many court cases, but some of the landmark cases define the legal and help define and think about the ethical aspects of this type of care. One of the most famous was the case of Karen Ann Quinlan. Ms. Quinlan suffered an anoxic brain injury and was dependent on a ventilator in the 1970s. Her parents felt that she would not want to be kept alive in this state. She was diagnosed with a persistent vegetative state. And they asked the doctors at her hospital to withdraw the ventilator. The doctors at the hospital did not feel that this was a medical thing that they could do. And the case was brought to court with a guardian appointed by the state, arguing with the county prosecutor that the idea of removing a ventilator from a patient could be negligent up to the point of criminal homicide. So very different sort of framework and thinking than our current. Ultimately, this was litigated through the courts and went to the state level, New Jersey Supreme Court, who decided that it was within the patient's rights, particularly the right to privacy and other legal aspects, that the parents could choose to withdraw the ventilator, using their substituted judgment. What is also important about this case and others like it is, many of these types of cases were being litigated around these times, and there was recognition within the judicial system that, many of these ended up being, medical questions and medical indication questions that shouldn't necessarily be litigated each time through the courts. You may have been involved in situations that needed to get legal involvement or go through the courts, but certainly if you've been involved in the withdrawal of ventilators, that we don't need to go through court decisions, or certainly have cases litigated through state Supreme Courts every time we withdraw a ventilator. That's in part because of the precedent of these landmark legal cases, but recognition and sort of establishment through the judiciary that the decision-making around these types of things should really happen between patients and physicians within the physician codes of standards of practice and professional practice and medical ethics. And so around this time, particularly after this case, we really saw the development of the field of clinical medical ethics and the establishment of bodies within institutions, medical institutions, such as hospital ethics committees, to help make these types of decisions without needing to use the legal system or go to court. So the Karen Ann Quinlan case was a landmark decision around the removal of a ventilator. The Nancy Cruzan case was about the perpetuation of artificial nutrition and hydration. So Nancy Cruzan was in a persistent vegetative state after a motor vehicle accident. 5 years into this, she did not require a ventilator, but she was unable to swallow, and her nutrition was given artificially by feeding tube. Her family felt that she would not want to persist in this state. She was also diagnosed in a persistent vegetative state and petitioned for removal of the feeding tube. This was the first case of these broad cases around sustaining or withdrawing life-sustaining interventions that went to the US Supreme Court. And the US Supreme Court drew a distinction between the patient autonomy and the constitutional right to privacy, where they felt that a patient that was competent, again, because it's a judicial decision, but certainly had capacity, but was competent, could choose to stop, withhold, or withdraw life-sustaining interventions. But they set the legal precedent that at the state level, or that as opposed to the patients themselves and their own autonomy, surrogate decision makers could be held to a higher standard and could be expected to produce a body of evidence about the patient's wishes, with the idea being that these are life and death decisions, and it would be appropriate because we don't, in the absence of truly knowing what the patient themselves would want, to hold their surrogate decision maker to some standard of evidence that would support that the patient would not want to be kept alive in a state. And so this was sent back to the Missouri courts to be decided. And ultimately, Ms. Cruzan's feeding tube was removed and she passed away 12 days later. This precedent, legal precedent, sets up what I described in the first part of this, wherein patients themselves do get broader autonomy, both ethically and legally, than surrogate decision makers. And so that's why you need to look at your own state statutes, because that's what's going to determine whether a surrogate decision maker can withdraw life-sustaining interventions, and with what sort of evidence or burden of proof they need to do that. It often depends on, such as in Illinois, legally, whether the patient is diagnosed with certain conditions, such as irreversible neurologic condition or terminal progressive illness and things like that. It also, sometimes a person who has a documented healthcare power of attorney has more authority to do this than someone who is just the substitute decision maker by state law or appointment. And that's another reason why it's important for patients to fill out a healthcare power of attorney if they end up in these situations. And part of the reason why the documents for advanced care planning can be very important too, because they can be clear evidence of the types of care you would want, or decisions you would want to make or not make, that can support a surrogate decision maker's decision to remove, withhold, or withdraw life-sustaining therapy. The Terry Schiavo case was a similar case. Ms. Schiavo unfortunately had a cardiac arrest, anoxic brain injury, and persistent vegetative state. This was a very contentious case that was widely publicized nationally, but was a Florida state case through the late 90s and early 2000s. Ms. Schiavo's husband was her substitute decision maker by law. But he felt that she would not want to be kept alive in this state and wished to stop artificial nutrition. Her parents wanted to continue artificial nutrition, and so they, those two parties went through many, many legal cases that were very contentious. And then this gained wide sort of, like I said, publicity and also political interest. Is one of those landmark cases because I think brought attention and some legal precedent to the issues of withholding artificial nutrition. Ultimately, it was granted after many cases and appeals for Mr. Schiavo's husband to be able to do this based on the idea that he had produced sort of sufficient evidence that Ms. Schiavo would not want to be kept alive in this state. The Florida state legislature actually passed a law at moments before the feeding tube was going to be removed, giving the governor at the time the ability to intervene in this case. So really, very sort of micro intervention in medical decision making by legal and political bodies. Ultimately, that law was deemed unconstitutional by the Florida Supreme Court. And Ms. Schiavo did ultimately have her feeding tube removed and passed away shortly after. But a very sort of widely publicized case that sort of energized what is colloquially referred to as right to die cases, and strong advocacy groups on both sort of sides of the decisions around withholding or withdrawing, particularly artificial nutrition. So, those cases and others established a legal framework that exists. And also, I think as the legal was moving forward over this time period, much ethical, philosophical, and debate among medical practitioners that arrived at our current practice, which I described. So we've established that Ms. J does not have decision capacity. Her power of attorney in the state that she is, meaning physically, like she's in, like I said, she's in the state of Illinois. She has as that power of attorney in the setting of terminal illness, she can appropriately elect to withhold or withdraw mechanical ventilation and CPR. So those things are done. Ms. J, as you remember, has presented with hypoxia, proceeding to respiratory distress and failure. So in discussion with her surrogate, her healthcare power of attorney, the focus is on relief of her symptoms and comfort, and she started on opioid medication to treat her symptomatic respiratory distress. This case is, occurs often at the end of life, but brings up a question and discussion of the ethical principle of double effect. Can an act that may cause harm be ethically permissible? Do no harm is foundational. Non-maleficence in the framework we discussed earlier is one of the core tenets of medicine. We arrive at this often in this situation. Mrs. J is hypoxic. She may be getting worse and getting hypotensive. Her mental status may be changing. Opioids can have harmful effects. They can cause sedation to the point of respiratory depression. They can also cause hypotension. And because of those things, they can shorten life. Is it permissible to do this to cause harm? And within the ethical principle of double effect, it is considered permissible in certain situations. I explained that. So these acts are permissible with criteria. First, the act itself has to be morally good or neutral. And the giving of opioids is at least a neutral, if not a good act. It can, it's something we do all the time and has medical indication. But acts that are inherently wrong, even if are meeting the other criteria, would not fall in this ethical principle of double effect. I think what's key to this too is that the person doing the act cannot be intending the bad effect. And that's really key. So, in giving opioids to someone for relief of symptoms at the end of life, the intention is to relieve symptoms. The intention cannot be to cause, respiratory depression or hypotension or end life. The intent must be the good act, not the bad act. You cannot use the bad act to produce the good act. If you were to give, a massive dose of opioids, knowing that would cause, sort of quick respiratory depression and, ultimately that the bad effects, that the sedation and the possibly shortening of life would achieve the good, in theory, the good effect of relieving pain and suffering, that cannot be the use for it. And what is key to that is proportionality. And again, both 2 and 3, you need to have the intent, and the intent needs to come through the good acts. And so in this case, giving opioids at appropriate doses and only as much as needed to treat symptoms would be a good act. That's what we do with opioids. And that's, the approach to take is you begin at, appropriate dosing, and you titrate only until symptoms are relieved. And when symptoms are relieved, you no longer titrate. You don't, use the bad effect like, respiratory depression or death to achieve the good effect. And the good effect must be positive enough to allow for the bad effect. Such as in this case, I think there is a very strong and positive imperative to relieve suffering of pain or dyspnea at the end of life by giving opioids, even if it does cause worsening hypotension or respiratory depression that could shorten life. And so those are, there are other cases in medicine where we cause harm, despite our imperative to do no harm, that would fall appropriately within this ethical principle of double effect, but especially the use of opioids at the end of life for relief of symptoms, is one that we are often running into. So Ms. J was started on opioid medications, and these were increased in appropriate increments until she was comfortable. So that was, appropriately using the doctrine of double effects. When she was comfortable, we were no longer increasing opioids. Often, one of the most challenging and evolving areas of medical ethics is what is called in different cases physician aid in dying or physician assisted suicide. This is different than euthanasia. Purposefully in working through these cases, we've chosen not to get into detail about those complex cases, which could be their own 2-hour ethics talk. But those are issues that are ongoing, vary by state, and are ethically charged areas. But Ms. J, we just received opioids just for comfort, and she was transferred to a hospice facility and passed away comfortably surrounded by family. So switching gears from end-of-life care to a different topic that I'll cover in a more brief fashion, but is one that is important and is extensively covered in the AMA Code of Medical Ethics, is privacy and patient confidentiality. So Mr. Yu is a 61-year-old man admitted to the hospital with fever and hypoxia. He has decisional capacity. His family is not allowed to visit due to visitor restrictions, which is something I know we're all going through right now. His daughter, who is his designated healthcare power of attorney, is transferred by the operator to the physician on call and asks for a medical update and copies of the medical record. We'll skip the contextual features of this case for time. The question is, can the physician give this information? So the patient autonomy extends certainly to the disclosure of medical information, and patients with decisional capacity decide whether and to whom their medical information is disclosed. For patients without capacity, a surrogate decision maker may generally receive information, but this varies by institutional policy and state guidance. This may also be limited by a patient's advance directives. There are exceptions that do not require specific consent, and you are able to release medical information in these situations without consent from the patient. The one is what we're doing every day to healthcare personnel, such as consultants, other members of the healthcare team, or healthcare operations for purpose of care or operation. So, a quality consultant, a hospital-based quality consultant, or the billing operations, you're able to give medical information to without the patient's specific consent, and we do that every day. Another issue would be appropriate authorities when disclosure is required by law. So again, another situation of consulting your local laws. But an example of this would be mandatory reporting of infectious diseases. You are ethically permitted and in some cases obligated to disclose without or even against the patient's consent in those situations. And then, what can be a less clearly defined or more difficult to deal with situation, which is you can disclose to third parties, such as individuals themselves or law enforcement agencies that are, third parties that are in a position to intervene if it is the judgment of the physician that there's a reasonable probability that the patient will harm himself or herself, or the patient will inflict serious physical harm on an identifiable individual or individuals. This is a famous landmark case around this was called the Tarasoff case. That was in the California Supreme Court. A psychologist in the University of California system had been treating a patient who indicated he intended to kill this individual. And he disclosed this to law enforcement, but they investigated and did not detain the individual. And then he proceeded to not detain the person who had been the patient. And unfortunately, he proceeded to kill the individual. These can be very ethically challenging cases. One generally of the legal and ethical considerations is generally the duty to break the therapeutic relationship and confidentiality, which no one should do lightly, is often more in the case when there is a specific individual or individuals being identified that could be intervened upon to protect. But these are cases that I would encourage you to involve, with, if you have the time, local ethic and legal guidance. So on the phone, the physician informs Mr. Yu's daughter that he must obtain Mr. Yu's consent to provide this information. Mrs. Yu's daughter states she is entitled to information because she has documented healthcare power of attorney. Again, I think we're having a lot more phone conversations because of visitor restrictions, and it can be really difficult for families to be away and not be getting information is one of the reasons I included these cases. And these types of issues are coming up a lot. So Mrs. Yu's daughter may be right. Legal documents may include permission to receive medical information, depending on the healthcare power of attorney or the living will or other documents we discuss. There can be legal statements on there allowing for the release of information. Those documents are often in the setting, defined in the setting I do have capacity or don't have capacity, or in any setting. If those legal documents are in place, then information can be relieved, given, but the documents must be reviewed and confirmed before information is given. Mr. Yu's healthcare power of attorney did not include a release of information, so this was explained to his daughter. Mr. Yu later consented himself for release of information, and she was provided the medical updates. So I'm going to stop there and turn it over to Dr. William Parker. I know too, these we are covering many different topics with many, many different features, and I know your guys' questions. I too can also try to address some of them in the chat, and then we'll try to leave time at the end. But I know that there will be much more questions than likely time we have for in trying to get through many different ethics topics. So Ms. Dahlia, if you can give the screen sharing now to Dr. Parker.
It looks like I have control, Mike. Thank you. Yeah, so I'm Will Parker. I'm an instructor of pulmonary critical care medicine at the University of Chicago, assistant director of the McLean Center for Clinical Ethics there. I did want to answer one question I thought that was really good in the chat, and it came up a couple of times, of the distinction between strictly futile interventions in the hospital and potentially inappropriate care. I think this is something that we struggle with a lot from an intensive care standpoint. Futile interventions are those that won't work and won't achieve their desired endpoint no matter what you do. Strictly speaking, the idea conceptually is you have a bucket with a bunch of holes in the bottom and you pour water in and the water just pours right out, right? You're not going to, if you give antibiotics for myocardial infarction, you're not going to improve that patient's mortality, right? That's strictly futile. In contrast, potentially inappropriate care often is effective. For example, putting someone who has advanced dementia and pneumonia on a mechanical ventilator, well, that will physiologically keep that patient alive. The problem is that, that will lead to a prolonging of the dying process, potentially eventual death at a long-term assisted care facility after more interventions are performed and more suffering that the patient has undergone. So that's what the fact that the mechanical ventilator works in a physiologic sense to keep the patient alive is what makes us feel uncomfortable about it and makes it potentially inappropriate. So in that sense, it's not actually strictly futile in the context of in the context of a therapy that just won't work. And so this framework has been adapted by the American Thoracic Society of Critical Care Physicians. It was a joint statement for multiple different societies. And I think it's a useful way to think about these decisions. But with that, I will turn to my content. And we don't have a lot of time left, but and I'm going to talk about research and medical intervention, medical innovation for about 10 minutes, and then finish up with allocation questions, which have been becoming especially relevant during the COVID-19 pandemic. So the case we have here is a 50-year-old woman with hypertension, admitted with fever and hypoxemia. She's diagnosed with COVID-19. a research team at our hospital was very anxious to enroll her in an experimental study therapy. And, you know, what are the ethical considerations that we should think about before experimenting on patients? And, you know, considering the ethics of medical innovation is impossible without the historical context. And I think it really starts with Nazi Germany and the atrocities committed by the German medical establishment during the run-up and during World War II, during the Holocaust. Prior to World War II, the German medical establishment was the leading institution in the world. In 1931, during the Weimar Republic, guidelines for human experimentation document that actually contains 6 out of the 10 points of the Nuremberg Code. So, you know, they were the thought leaders in a space. They had developed the idea of informed consent that we've already discussed ad nauseum. We developed the idea of protection of research subjects. The problem was that this obviously had the lack of political will to follow through on those, and obviously lost the respect for persons idea, which will come up in the Belmont report as we move through history, that's so critical to protecting research subjects. Obviously, they started to think of all of the victims of the Holocaust, Jews, homosexuals, gypsies, to being less than human, things that could be experimented on for the greater good of the Republic. And that enabled all sorts of horrendous atrocities. I'm sure we've all learned about them in medical school in different times as a warning for physicians that hopefully we never forget, from the freezing experiments to the high altitude pressure deprivation experiments to Mengelé's atrocities with twin experiments at Auschwitz. So the Nuremberg Code came directly out of the trial verdict for the doctor's trial in 1947. It wasn't actually at the time publicized that widely. It was just sort of buried in this verdict. Obviously, the Nuremberg trials were huge news, but it actually didn't really become popular until the Declaration of Helsinki in 1967, which we'll get to in a second. And as I mentioned before, the actual content of the code was developed, 15 years prior by the Germans themselves. So this is the 10 points of the code. Not going to go through them in detail, but I want to point out underline a couple things that I think will be salient as we go through more of the history. First is that voluntary consent of human subjects is essential in the Nuremberg Code. Nuremberg Code wouldn't even allow for surrogate consent for medical research. And that, there's a lot of these points deal with this idea that the degree of risk to be undertaken by the subject is never greater than the benefit of the study, right? So the study from a utilitarian standpoint is expected to be worth it. So whatever risk the people are signing up for, reasonably we can expect the benefit to society from the information gained from the experiment to outweigh that. And then, some of these other ideas speak to this respect for persons argument that you should go out of your way to protect subjects from injury and disability and death. And anytime you're exposing a subject to harm, you have to have incredibly good reason to do that. And people should be able to stop and get out of the experiment whenever they want to. And so this again, these ideas had actually predated Nuremberg. They've been around for a while. And so they were certainly not new things. But nevertheless, during starting in 1932 and going all the way to 1972 in the U.S., we perpetrated a horrendous breach of medical ethics of the Tuskegee syphilis experiment. Sure, where most of us are familiar with this in some detail. The one story I've been told about this experiment that I don't think is quite true is that even in its conception, it was well intended, that there had been this big study of untreated syphilis, which at the time in the 1920s, there were no effective treatments for syphilis in the white population. And, these good intentioned researchers wanted to repeat the study in the African-American population to see if there were any important racial differences in the progression of the disease. But, already there, I think the construction of the study belies the inherent racism that was involved, because they took essentially sort of a captive population of very poor sharecroppers who had no access to healthcare, and promised them free healthcare as payment for entering the study, and then kept them in the study, observing them without treatment, straight through the development of penicillin in 1947. The participants, by the way, there was a syphilis arm and a control arm, and nobody knew what their syphilis status was. And they were never informed of that. And they were, in fact, actively deceived by the investigators over time and prohibited from receiving syphilis treatment. So, in some ways, these aren't very much different than the Nazis. This wasn't very much different than the Nazis, right? It's treating these people not as people, and as it's sort of mere means to the end of the experiment. So I don't think there's many redeeming qualities in this, even from its construction. It was a product of the racism of the times, and this has been formally apologized for by the U.S. government multiple times. I think that timing is important, because the Nuremberg Code was right in the middle of this, 1947. The principles of the Nuremberg Code had been around since 1931, so this wasn't anything new. There are also a couple of other, in the 60s was sort of the great awakening to medical research ethics, because there were a couple other horrible clinical trials, in quotes, that had been performed in the 50s. Another famous one that I didn't mention here, I don't have time to go into the details, was with the Willowbrook state school experiments, where mentally retarded children were intentionally inoculated with hepatitis A. And again, the justification there was, oh, most of the kids at this school get hepatitis A anyway, so if we intentionally inoculate them, then we can better observe the natural history of the disease and add to knowledge, right? And the only reason that calculation makes sense in your head at all is that these children were all mentally handicapped, and the investigators were treating them as less than human, just like they were the sharecroppers in the Tuskegee syphilis study, just like the Nazis treated the concentration camp victims. So, there's a common thread throughout all of these horrible violations of medical ethics in research, and it's that the investigators are treating the subjects in the study as something other than persons. So the Declaration of Helsinki was when the Nuremberg Code really became popular, because they took the 10 principles of the Nuremberg Code and expanded upon them, modernized a lot of the concepts, allowed for surrogate consent. And this was around the same time that there was a really famous New England Journal article by Henry Beecher exposing the Willowbrook study, for example. Didn't expose Tuskegee. That was until 1972, and also 10 other studies that were unethical. So the Declaration of Helsinki, sort of started the modern era of clinical medical research ethics, where we started to have more oversight, more ethics injected into these appropriately restraining investigators. And as I mentioned before, the Belmont Report in 1978 was commissioned in response to Tuskegee by Congress, and they developed these three core ethical principles: that you should have respect for persons, and that I've mentioned a couple of times, which is that maybe the idea is that you're recognizing you are putting human beings in harm's way by randomizing them between two different treatments or subjecting them to a new experimental therapy. We'll talk about phase 1 trials in a second that have never been tried on a human being. And, that requires the utmost care and caution. And you can never forget that that's what, these people, the participants in the study are making, taking a big risk, and that they're in people, and you have to respect their autonomy. And the Belmont Report also is responsible for the establishment of IRB boards, which are supposed to formally oversee this process. And the Belmont Report is one of their main resources that an IRB does when they're evaluating the study. The Health and Human Services Common Rule is actually more of a detailed regulations of how the IRB is supposed to operate. The Belmont Report sort of outlines the broad ethical principles that I was mentioning. The Health and Human Services Final Rule gives the IRBs the details about how they're supposed to ensure the principles in the Belmont Report are followed. just want to keep moving quickly here. We only have 7 minutes. So I think I'm going to skip through informed consent and medical research. I think it's relatively similar to informed consent for any therapy, just that, again, there has to be this added layer of caution and care taken. The idea that you can sort of get off the train at any time has to be reinforced over and over again for participants in clinical trials. I'm going to skip this slide because we're running out of time in detail, but generally one of the problems with informed consent in practice is that it's very hard to convey the uncertainty of and the lack of potential of therapeutic benefit to patients for new therapies. So we saw this in COVID-19. They're being thrown patients in uncontrolled phase 1 trials just to see if they're safe, like convalescent plasma, for example, is in the news a lot. Without a control arm, where they're not actually studies of efficacy, right? You don't actually know that you're not demonstrating with your study that the therapy is effective, but nevertheless, patients believe that they're going to be the one who has this response, right? So that's inherently an inherent challenge to the informed consent process in medical trials. All right, so I think I've hit most of the high points in terms of the physician researcher's responsibilities. With that, I think I'll spend the last couple of minutes talking about allocation. Unfortunately, I think we're running really short on time. So hopefully that Gina and Mike can help me by answering any questions that are at the chat. Allocation of resources has been a huge topic recently during the COVID-19 pandemic. Very early on, it looked like the surge. It's very possible that the surge of patients in the U.S. and various other countries around the world completely overwhelm our capacity to provide critical care and specifically mechanical ventilators. Here's a scenario where a new patient is shown up, needs a ventilator, but the ICU is already full, and there's a bunch of patients on ventilators. So are you going to take somebody off to put Mrs. Q on? Withdrawing and withholding are supposedly equivalent, right? How are you going to allocate this incredibly scarce resource to save the most lives and make this tragic choice? Thankfully, we didn't have to do this in a widespread fashion. In New York, there may have been more informal allocating or rationing where there were lots of palliative care interventions early in the ER, and people were being very aggressively talked about the risks of prolonged mechanical ventilation and engaging them in shared decision making. Probably the things we should have been doing anyway, right? Before putting anyone on mechanical ventilator, that prevented us from being completely overwhelmed in New York. So a crisis standard of care is this concept that's important to get our heads around when we're thinking about when we have to allocate scarce resources. And that's when there's this, a viral pandemic or Hurricane Katrina hits and completely overwhelms the healthcare system. There's a situation where there's 20 patients arriving a day who are going to require mechanical ventilation to your hospital, and the ICU is already completely full. And there's, or in Katrina, when there's a power blackout and you only have a backup generator for your hospital and you can only mechanically ventilate 5 patients. And these are the types of terrible circumstances where the physicians or the people allocating the resource have to decide who's going to receive it amongst a group of patients who are going to benefit from it. Fortunately, we never really got there. So I only have 2 minutes left, unfortunately. I know we have a very busy schedule for the rest of the session here. So maybe I'll just sort of conclude with the AMA's opinions on this, on how you should allocate resources in the setting of true scarcity. You need to base allocation policies on criteria relating to medical need. You're not supposed to use non-medical characteristics. So subjective information about the patient, whether or not they're a friend of the CEO of the hospital, of course, is blatantly unethical to be used in an allocation decision. And you're supposed to assign resources such a way to maximize number of lives saved, right? So you want to give, from a utilitarian standpoint, the life-sustaining therapies to the patients with the greatest chance of benefiting from it. And there's an active argument about whether you want to save the maximum number of lives you can, or if there should be some consideration of age. So younger patients who have more expected life years should be prioritized higher. And that's an area of active excellent debate. And finally, it's incredibly important that any allocation system be transparent and open to the public. I'm just going to conclude by skipping forward to recent work by Gina Pistello and I that was published last week, actually, about the heterogeneity in allocation policies across states. The big takeaway, still 10-15, you're telling me, which is good. So I'll have some time to finish, to loop back and dig into more of the ethics. But I think this is a good segue anyway to talk about how, even though there's some broad consensus on policies needing to be open and transparent, and there'd be some ranking system that ranks people with higher, who have higher expected benefit from the therapy, higher for the allocation, there's incredible variation between states in terms of what's actually done in practice. So, first of all, Gina found that 26 states don't even have a policy. That's in the light gray here. And the dark gray here represent states who have no exclusion criteria. What are exclusion criteria? Exclusion criteria are a set of rules that say, in the setting of a pandemic, these people are not eligible to receive a mechanical ventilator, for example. So some of these examples would be patients with severe burns that are covering more than 50% of their body surface area, patients who have an expected mortality in the hospital, over 80%, for example, or using a SOFA score cutoff, which I'll explain what the SOFA score is in a second, because it's incredibly important for all these allocation systems, of 11 or higher. So patients with incredibly high expected mortality are just excluded from ventilation altogether. However, several states in the dark blue do have these criteria where if you meet those characteristics, you show up at the hospital during a pandemic when we're in a crisis standard of care, they'll be excluded from ventilation. And then there's some states that discuss them but don't actually make a recommendation. And so this and the next graph plot in particular demonstrates that there's maybe some broad ethical consensus about what are the really high-level principles of how you should allocate a scarce resource in the setting of a crisis standard of care. But when you drill down to the details in practice, the states have made widely different practical recommendations that I think have ethically important differences. So this is what the actual scoring system that would be used in these various states. All of them use something called the sequential organ failure assessment score. Those of us who work in critical care related fields might be familiar with this. It's a score that assigns 0 to 4 points for different organ failures. So across 6 organ systems. So if all, and they're like renal, hepatic, respiratory, cardiovascular, the amount of pressors you're on, what amount of ventilatory support, whether you're in renal failure or not, all gets you more or less points. And it turns out it's been pretty well validated in terms of predicting hospital survival. And it has the added benefit of being able to be calculated at the bedside and quickly and quickly determine a patient's prognosis. And so the idea here is that you would prioritize patients with lower SOFA scores in order to save more lives overall. However, the way that states actually decide to use this information varies dramatically. I think the first time we put this together, like each state was almost its own color because there was so much material differences between the different state ventilator allocation rules. We were able to find some commonalities, but there are some states that use just the SOFA score and that's it. And then other states blend in more information, like, for example, life-limiting conditions, age, other different comorbid conditions, projections of how much life expectancy the patient is expected to have if they survive their critical illness. So now will probably be a good time for me to loop back and discuss the ethics about why why some states are considering things such as age and chronic conditions and other states decided not to, and the inherent ethical tension therein. So I'm going to slide back to my ethics slides. So basically, when you think about designing an allocation system, this is from a 2009 paper in The Lancet, I think that really well describes the ethical landscape in this area. I encourage people to read. But you can imagine like a set of principles, simple allocation principles that you could base your system entirely based on, right? So equity is this idea that independent of their medical status or all those other considerations. This would be, in theory, what would motivate a first come, first serve ICU allocation system, right? You're just treating patients as they roll in the door. You're treating everybody the same. Now, we all know that patients with higher socioeconomic status have better access to healthcare. That in first come, first serve as an allocation mechanism is anything but equitable in practice, right? So a lottery system where everyone who is potentially eligible gets entered into the lottery would probably be more equitable in practice.
Okay, he's almost.
Excuse me. The next set of principles is this idea of prioritarianism, big word, but means favoring the worse off. And this is I think an intuitive thing that physicians, we often feel, who's the sickest patient? I'm going to spend the most time on them. And we should honor this rule of rescue and allocate them the resource because they're nearest to death without it. This is what actually underlies liver allocation with the MELD score. Now, the problem with it, as we'll get to in a second, is that it doesn't necessarily maximize the total benefit to the population. If someone has a really bad prognosis with or without a mechanical ventilator, they're probably not the best use of that ventilator from a utilitarian standpoint when you're trying to maximize the total number of lives saved. And that's this third column of utilitarianism here. And utilitarianism is what motivates the triage rules for wounded soldiers on the battlefield. The medic runs up, he sees 100 of his injured friends, he has to decide who to treat first. They quickly pin people into red. Those are the patients with the highest probability of survival with treatment and the lowest probability of survival without. Green are the people who don't need treatment. Yellow are the people who you might be able to save with treatment, but probably won't. And then blue are the people who are too far gone. And so on the battlefield, they very quickly have to make these triage assessments in order to save the maximum number of soldiers. So that type of framework has been ported into the medical context in many of these allocation schemes. And then finally, there's two other different types of ethical considerations that are very common. One is youngest first allocation. So this idea that younger people who are critically ill or sick, who have a risk of death early in their life, are worse off than older people who are critically ill or sick, because older people have gotten the ability to live a full life. Sometimes this is described as fair innings, or playing your maximum number of innings of baseball or cricket. And it's not fair if someone hasn't got to play all 9 innings of baseball, they're only 3 innings in. Therefore, from a fairness perspective, we should allocate them more resources. And this is
sorry to interrupt.
Oh, sorry.
Can you wrap it up in a couple of minutes?
Yes, of course. I thought, do we have till 10:15, or should I can be done after this slide? Whatever's best. I definitely want to respect everyone's time. So I'll just finish one or two more thoughts and then wrap it up, see if there's any discussion questions. The point of going through each of these in turn is that if you build your entire allocation scheme based on just one idea, then you're going to create sort of fatal flaws in other areas because you ignore those other relevant principles. And so if generally people have started to come to the consensus So if people have come to the consensus that we have to combine these principles in some way to develop a multi-principle framework, and that sticking with the status quo, which in the case of ventilator allocation is just first come, first serve, leads to ethically unacceptable consequences, right? We have to do the hard work of engaging these principles, figuring out how to balance them in some way that's acceptable to a wide group of shareholders. And that's clearly not been done. I think just Gina's work that was published last week demonstrates that, right? It depends on what state you're in about how these different ethical principles are going to be combined into an allocation scheme. This paper in the New England Journal by Ezekiel Emanuel that came out early in the pandemic is also a great resource. I encourage people to look at it. It kind of goes through a lot of these same principles and recommendations for how they should be used. I would note that early on, Ezekiel Emanuel was also on the Lancet paper back in 2009 when he was like 11 years younger. And that one talked a lot more about this fair innings concept, about prioritizing younger people so they can live complete lives. And in his more recent New England Journal paper, that idea has been completely dropped, or de-emphasized rather, and lowered in priority. Maybe it has something to do with the fact that he got 11 years older and wasn't quite as young anymore. But I think it also underscores the fact that Ezekiel Emanuel is arguing with himself over time that this is not a settled issue from an ethical perspective about how to put these very abstract pieces together into a practical allocation system, and a lot more work needs to be done in this area, hopefully before we get to the next pandemic or the next surge, and God forbid they start having to do this in the South, and hopefully as a nation we can redistribute resources so that doesn't happen. But it's the threat is still there globally for sure, and the need to better understand these the way that these ethical principles translate into practice is huge. So yeah, I guess I'll wrap up now with sort of the general points of consensus. Sorry, we were kind of jumping all over the place, but first come, first serve is not acceptable for an allocation system. Triage committees, not frontline providers, should be making triage decisions. I don't think this is something I emphasize enough, but this is bedside physicians shouldn't be doing this on the fly, right? There should be a triage committee that's executing the protocol, that's drawn back from the bedside, that can do it sort of in an objective way and remove all those subjective influences that are typically unethical. And you should use objective scores and algorithms. And then there's controversy about whether healthcare workers should get priority or not. I won't have time to dig into that can of worms. I think with adequate PPE, you could argue that me in my weeks in the COVID ICU recently, I was more protected than the essential workers delivering from my food. So do I really deserve, from a reciprocity standpoint, priority for a ventilator? Maybe you would argue I have instrumental value. If you bring me back, I'll take care of other patients. That's probably a little thin if you actually start doing the math and the probabilities. So, and then finally, you should use a lottery in the end for patients with equal prognosis. So with that, I will stop. Leave a couple minutes to wrap up in questions. I'm sorry about the time confusion and the disorganization, but hopefully everybody was able to follow it. Thank you.
That was great. All the presentations were really very interesting and great. And I think we are okay because we started a little bit late. So you're fine, Dr. Parker. There's one question here which has come up. Is just,
okay, thank you.
And it says just signed and witnessed is enough to make it legal, and it doesn't need to be notarized also?
Maybe referring to the advanced directives documents, and that varies by the state policies and the documents themselves. Many of them do not need to be notarized. You just have to know the particular document in your state statutes.
Okay, that's good. Let me see if there's any other question there. I don't see any other question. Let me check again. I think that's the only question we have here, which really means that, oh, there's one. No, I think there are a few comments here saying they were really excellent presentations, and I'll echo those comments too. And I think when there are no questions, that means either people have understood everything or they didn't understand anything. And I think the former is correct here. So really, congratulations for really excellent presentation. I'll give the defer to Dr. Dr. Vemuri, if he wants to say anything.
Thank you, Dr. Nanda. As we can all appreciate from the webinar, medical ethics is an important and intricate field of medical practice. It involves a rational, legally guided, and evidence-based objective decision-making process. We are happy we have a panel of distinguished physician clinical ethics experts sharing their experiences with us today. I wish we had more time. Thank you, Dr. Michael Huber, Dr. William Parker, Dr. Gina Paistello, and Dr. Naveen Nanda. Thank you all for joining the webinar today. Please attend tomorrow's session starting at 8 a.m. CST. This ends today's session. Have a good day.
Okay, thank you. Thank you very much.